Ahead and get going here. OcuSci has been around for going on 13 years now, and we really only do dry eye treatments. That's really what we do, products and treatments. And we are all over the world in hundreds of clinics. We've got multiple published studies. I'm going to cover a couple of those here briefly. And I'm David McMahon, I should have said, CEO of OcuSci. I've been in medical device for 26 years now, so been in many different areas, but focused in dry eye for the past 12 years. So OcuSci offers, we're really the only company that offers the full continuum of dry eye care. So everything from in-clinic treatment, which is the MGRX, to dry eye supplements, to really what we think is the world's best dry eye compress. I'll let you make up your mind on that. We'll talk about that a little bit. And our new USB compress as well. We also have a really nice ultramacular product for macular degeneration. So world's best dry eye compress, question mark. The goal with the dry eye compress is to heat the meibomian glands and help melt that meibum and facilitate the secretion, really get those glands flowing again. And then, of course, the heat itself will increase vascular blood flow to the tissue, which helps repair that inflammation and treat that. A washcloth does not work. There's been several studies done that proves you need to get the eyelid temperature over 40 C. In fact, there's a very specific study that says 41.5 is really, says maximum here. It should say the most efficient temperature to melt meibum, the most effective. Oops. So what makes our compress different? A couple of things. If you're using, several of our competitors out there, you'll notice that ours weighs about 45% more of the natural mineral. And what that does, it just delivers just a greater mass of moisture for a much longer time. The other thing that really sets us apart is this hydro block that we have on the front of the compress. If you can imagine the compress on your face, this actually is a waterproof layer that blocks the heat and moisture from escaping out the front and sends it back to the patient. So we're the only ones who have that. It's a patented feature. We also have a 1-year warranty, which no one else offers. So if you haven't tried our compress, really encourage you to try it. We will be sending you samples for attending today, and you'll be able to try it. One last thing is we do put, we will actually put your logo right on the compress. We're the only company that will do that as well. And so, as I just said, moisture is key. And if you can follow this blue line here, this is relative humidity. 20 seconds in the microwave, and you can see our relative humidity stays over 95% for 10 minutes, as well as the heat. So this is can be a 10-minute treatment of moist heat. This is one of our very well-known competitors that, as I mentioned, weighs about half of what ours does. It just doesn't have the mass to produce the moisture that ours does, and thus is just not as effective. Many studies, again, that moist heat increases blood flow 35% more than dry heat, so the same temperature, so very effective. And then, again, we're big into studies. Everything we do, we want to have really not subjective, but objective evidence on the function. So here's some thermography that we've done, and we'll be turning these into some studies, but basically your temperature of your eyelids is about 99 degrees. Using our compress, which 20 seconds in the microwave is about 120 Fahrenheit, 3 minutes in on your face, delivering that moisture, raises your eyelid temperature almost 8 degrees. And so that's really hitting this optimal temperature to melt the meibomium, the meibum and the meibomium glands. So 3 minutes of treatment there. Here's a dry eye compress that a case study, sorry. Someone needs to go on mute. Somebody's not on mute. Everyone take a look at your, there we go. Okay. There, I think we may have gotten it. Okay. So as I was saying, here's a case study, again, with our compress, 5 days of use, 5 minutes a day, and they got 123% increase in tear breakup time. So from less than 6 seconds to, 20, and this is using the Keratograph 5. One other study to cover real quickly here, our ultra dry eye TG, so triglyceride omega-3, wild caught in Alaska, same one we use in our dry eye complete. It's just a bit of a different dose. So 5 minutes a day of our compress plus 3 of these soft gels per day. It's an omega-3 plus vitamin D plus lutein, actually. 30 days of treatment. And you can see that we had a 49% decrease in the ocular surface disease index, the OSDI, in just 1 month. And maybe more impressive, half of the patients were actually asymptomatic based on OSDI after 30 days. So, and all patients had some improvement. So you don't see that in many studies. So we're very confident in saying that this is really going to help you in 30 days. Oops. Tear breakup time, 81% increase in tear breakup time, again, 30 days on that protocol. Very simple protocol to use at home. So those are a couple clinical studies we've had published. And now let's talk about the MGRX. Really is the only triple modality system for MGD. So no disposable required. I'm going to walk you through those three modalities. Depending on how you do it, 5 to 10 minutes of clinician time can actually be 0, and Dr. Valdez will talk about that. Because there are no disposals, because it's very affordable, the return on investment is 20 to 30 patients, depending on what you're charging in your practice. 4-year warranties, bumper to bumper, so no concern about the device breaking on you. So what is the MGRX system? So a couple of components here. The handheld device you saw is a battery-powered device. This preheater, the only function of this is to get these instruments that are interchangeable in the handpiece up to temperature, which we're looking for 42 to 45 Celsius. So, 106 to 110 in Fahrenheit. And the reason we have this preheater is because we want to save battery and we want to save time. So the MGRX handheld can do all of this, but it's much more efficient for us to use this plugged in heater to get these instruments up to temperature so that you can switch them out very quickly and not have to wait around. So the 3 modalities that we talked about are thermal debridement. So you're decapping glands, removing biofilm. This is maybe 2 minutes of time. Definitely could have your tech do that. Step 2 is thermal lid massage. So heated massage, built-in 2-minute timer. It's 2 minutes per eye. Again, easily performed by a tech. This is external, to the eye. Step 3 is the expression where we're able to really clear out those glands. And obviously these first 2 really help with this third. And again, this is 2 minutes, I would say, and you could have your tech do this as well, although a lot of docs like to do it because it's really kind of the payoff step here. So I want to now show you a real quick, this is like 1.5 minutes, but I know it's hard to visualize maybe this in use. So I just want to give you this quick look at these so you understand which each step is. And then I'm going to turn this over to Dr. Valdez, who's really going to dig deep into these, into the kind of the state of treatment and disease in this disease space. So here we go with the video. So you are going to want to use some proparacaine drops just to kind of calm the nerves. So here you can see debridement on the upper lid. Just kind of a dull golf club spud. Thermal massage, you're going to use some ultrasound gel just to help transfer the heat and reduce friction. It's got a built-in 2-minute timer. It's very comfortable. I've had it done 3 times myself. Thermal expression. So here we are, the red expressor, the paddle, the external paddle is heated. The blue, the internal is not. So we're keeping heat. And it's easy to treat both the upper and the lower lids. You can see those angles make it very easy to get into those lids. Again, a couple drops of proparacaine before you do this. I think you're going to see a close up here. Yeah. You just want to get those paddles about 3/4 deep, at least, into the eyelid. And then it's pressure limited. So you're not using a ton of pressure to express those glands. It's less than 10 PSI. So again, comfortable for the patient. And since we've debrided and we've heated that meibum, it's easy to express. Oops, we don't want to watch that again. Whoops. Okay, so without further ado, we're making good time here. It's really a treat and an honor to have Dr. Valdez here today. You can see his biography there. It's much too long to read because he's so accomplished. I'll just read kind of the top 3 bullets and a couple of highlights here. Dean of School of Medicine in Monterrey, Mexico, Director of Cornea and Refractive Surgery, Director of Advanced Therapies and Visual Science. He's the president, or has held the president of the Mexican Society of Ophthalmology. He's won awards for International Ophthalmologist of the Year, and over 120 publications, 5 books and 8 chapters. So I think when I was talking to one of his staff at Arvo this year, I think he summed it up best when he said, he's the Michael Jordan of ophthalmologists in Mexico, right? So I thought that was really good. So without further ado, I'm going to turn it over to Dr. Valdez.
Okay.
There's one microphone open.
There we go. Someone's got their mic open. Yeah.
Okay. Okay. Thank you, David, for this kind introduction. Very nice from your part. Can we show the next one?
Yes. Whoop. I'm controlling.
So we were talking about our first early experience, because we just got the MGRX, and so we will show you this case series pilot study that we just start to know this device. But I can tell you in advance, we are very happy. We have been working in this, and I will show you the different studies that we have. But this new device has a special place in our strategy to treat meibomian gland dysfunction. So just a quick introduction. Dry eye disease, is a very common ocular condition. Prevalence from 7.4 to 33%, and probably higher here in some areas of northern part of Mexico. That's pretty similar to south part of states. There's very dry, low humidity around us. We can organize the dry eye disease in 2 functional categories: aqueous deficient and evaporative. So we will focus in this last one in this talk to be effective, a treatment should be aimed at the underlying etiology. Can we go back a little? Yeah,
Yep.
thank you. Aqueous deficiency, of course, when the production is insufficient, but we were talking about evaporative dry eye disease. And this is due to the instability of the tear film, and this is due to the meibomian gland dysfunction. So let's focus on this meibomian gland dysfunction. Next, David, please. We know pretty well that, for example, age increased dry eye symptoms, and we see in our everyday clinical work here that has as the age increases, we have more symptoms, and probably due to, if you have patients in a large city like us here in Monterrey, it's a 5 million city with a lot of pollution, dry environment. We actually have really a lot of patients who complain about dry eye disease. Next, please, or at least have dry eye symptoms. And we know that around 80–90% of patients with dry disease have a MGD, meibomian gland dysfunctions. And for this specific patient, conservative treatment as the lubricant drops and ointments or gels, low-dose anti-inflammatory topical medication, and warm compresses is not enough. It's insufficient to control the signs and symptoms of dry eye disease. So in response to that, we have from the industry a lot of in-office technologies that the purpose of those is to provide a long-term relief from the symptoms of dry eye disease. Next, please. Yeah, thank you. We can define meibomian gland dysfunction as a term to use to describe a group of disorders, both congenital and acquired, linked by functional abnormalities of the meibomian gland. MGD can lead to altered tear film composition, ocular surface disease, ocular and eyelid discomfort, and as we already talk about, evaporative dry eye. Next, please. So MGD has been classified as a low delivery and with meibomian gland hyposecretion or obstruction, quite common. And the other is the one that is hypersecretion. We can divide this or split these entities into primary and secondary causes, as you can see in the slide. And but I would say the main number of patients, the majority of patients, come from this obstructive meibomian gland. This dysfunction is due to this hyposecretion, and the origin is that it is obstructed. Can be by scar tissue or can be by the same the change in the lipid composition. Next, please. So getting into pathophysiology, MGD is a highly complex disease condition that is associated with several or is caused by several for example, host, microbial, hormonal, metabolic, and environmental factors. But the main, I would say that if you see the slide in the center is obstruction, but that can, as I mentioned, can be generated by changes in the meibomium. It can be in the quality that changes the composition or the quantity, and that can, well, that will at the end create a deficiency in the tear film, and an unstable tear film that allows a rapid evaporation from this cornea surface, creating all these symptoms of dry eye. Many factors around that can affect and create these meibomian gland dysfunctions. It's not it's associated, for example, with demodics, for example, or inflammatory diseases, but other causes can produce like any contact lenses, and even, and I will talk a little bit about that, refractive surgery. Next, please. So how we approach this? Well, the dry eye disease, we have a systematic approach in the diagnostic strategy. has been discussed and several have been proposed. The last one is from the DUCE study, but I like this slide that shows all the different approaches according to what we are finding. And would like to bring your attention to if we see lead margin disease and blepharitis. If we see that, we must focus first on that and try to work on that. Obviously, in our practice, we do all the office, I would say, slit lamp evaluation with Schirmer. We put the Lisamin green and all the dyes that we normally use. We even measure the lacrimal meniscus. We do meniscometry of those patients. But we also focus on the meibomian glands. Next, please. So, for example, we conduct this study about the evaluation of mammography scores as age increases in Hispanic patients. This was a retrospective study, case series 192 records of patients diagnosed with dry eye disease. And what we have found is that mammography scores tend to get worse with the as I already mentioned, the passage of time, such a different mammography score between those younger than 65 years and those older. This may suggest that changes may also accelerate after certain age. So we need to take more, how to say, detailed examination in older patients, because we will, for sure, we will find some alteration in the meibomian gland structure. Next, please. And also, as I already mentioned, we conduct also this study, the correlation between ocular surface disease index and the dry eye functional parameters using non-invasive method. In this case, and I think, David, you mentioned in the introduction, we use the keratograph 5, and it was very accurate in correlate what we do in the office and according to that. So we systematize the approach for the patient with dry eye disease, and we have a suspicion of meibomian gland dysfunction. Next, please. So this is how we categorize. We use this approach, in which is how we categorize the MGD: stage 1, stage 2, stage 3, and 4, and the plus disease, in which something else is in the surface, like Demodex or something that we need to take in account. So why this is useful? Because that will guide us in the treatment, what type of treatment we are using. And until now, before we got the MGRX, we treat the same way, the stage 1 and stage 2 with the straight like a stage 4. Now we can divide and stratify the approach for these patients. Next, please. So one back. You see in the treatment guide, the stage 2 is proposed that we use the warming and the expression of the meibomian glands. And since stage 2, we can use that. But sometimes they feel there's very basic using more complex treatment modalities. So let me show you what we are doing right now. Next, please. We already, as I mentioned, let me share with you this study that we presented at ARBO in 2017. And we started to do this in 2016, in which we were using the triple therapy that David actually mentioned at the beginning of the talk, and we use the debridement or scaling of the eyelid, the moist heat therapy, and the meibomian gland expression. And we have really an improvement, a significant decrease in the OSD score, and the improvement in the tear breakup time, and as well on the corneal staining scores after 3-week therapy. In this type of therapy, we use 3 sessions, one at the beginning, next week the other one, next week the other one. So what we call it the week therapy. So we have been using this for, as you can see, since 2016. Next. But now I would like to share with you our experience, and I really want to thank you, David, to allow us to have this here in Mexico. The MGRX system for the management of MGD related dry eye disease. Next. This is a really preliminary approach. Well, let me share you what with the first patient that we are treating. We treat 36 eyes from 18 patients. They were randomly selected, more on the incoming base, and then if we ask them if we want to have that. The MGD grade was 1 or 2 as inclusion criteria, and I will show you right now after that what was the real figure. No age, actually, we have a large age group. Obviously, in all cases, we did a complete ophthalmologic evaluation, and we use OcuSci and mammography to evaluate this patient. And the majority, as you can see, were females, and the age group. You see, the age range goes from 13 years, a very cooperative child, and 79 years old. The mean age for the female group was 45, around that, and a little bit lower for the masculine. But you can see all the different, the mean age is around 45. Next. And then the symptoms evaluation, well, we use the OSD6, that is the fast one. And that comes with the me check that I will show you device. And so mainly they have grade 1, 2, 3, but even 4. So the severity of the symptoms was goes from almost no symptoms to really severe symptoms. Next, please. And then we have, well, we use the me check for easy meibomian gland screening, because in that case, we only use the lower lid evaluation, and provides an automatic evaluation of the meibomian glands. So it's quite easy to use and does not take time. And as you can see, you can use it with your slit lamp. Next. And this is it. So we actually enrolled only grade 2. The majority were grade 2 and grade 3, just one grade meibomian gland dysfunction according to the mammography. Next. So what type of patients we were seeing? My practice is a really corneal refractive practice, as David mentioned at the beginning. Most of the patients were from post LASIK. That's the one. 7 of them, but also the presbyopia and myopia were actually pre-LASIK patients that were looking for surgery. And the small ones, that's blepharitis and glaucoma. We have 2 patients of glaucoma. Next, please. So I just bring this study because most of the patients that I was going to show you were from a refractive surgery clinic, and we know that refractive surgery may aggravate the dry eye symptom. It's really a very common side effect, I will say, after corneal refractive surgery. Our results in Mexican population are in accordance with other studies that gender and age influence the risk of postoperative refractive chronic dry eye. But even though that there is an evidence that chronic dry eye is due to neuropathic factor, we found a correlation between the meniscus height, the break-off time, the average break-off time, and ocular redness, in addition to superior and inferior meibography, the break-off time, the final first break-off time, and the average break-off time. So this association, awareness of this association and further studies, we need to understand better this post-refractive dry eye. Next, please. So I think David explained it and showed it wonderfully in the video, but we use this triple therapy modality. The breathement, the dry heat. This is very convenient, more comfortable for the patient according to them. Low the time consumed for this is really lower, and then the expression that is also well tolerated, and this is the way that we do it. We from the side, and it actually creates this pressure over the gland to express the content of that. Next. So let me, the experience that I have talking with the patients, because I saw all the patients after they have the treatment the next day. I asked them if they tolerate pretty well without any discomfort. They say that was very quickly. They were spending more time in the treatment room. All of them that they have a decrease in the symptoms, although we are doing the follow-up for the month. We will collecting the data for those patients. And a very important question that I bring from my experience in refractive surgery is if they will repeat the treatment, and all of them say yes. They say that they feel comfortable enough to, if we need it, they can do it again. Next. What is the opinion of the technicians? Here, I have in my team, there are several nurses that help us in the treatment. That really liberate my time to see the patient, talk with the patient, and not doing the procedure. But as the same as the patient, they say does not require much. They say does not require much preparation time. It's very easy to perform, not time consuming, according to the same way that the patient said, and very convenient that they don't have consumables that have to change or interchange. That's just clean the different instrument that we use, and that's it. It's ready for the next patient, and that creates we have a very busy clinic on cornea, in particular in dry disease. Around 40, probably 50% of patients are dry patients in our cornea service. Next. And this is my own perspective. As I mentioned, this is a report of serious cases that is being followed. We need to complete the 1 month follow-up really to do, again, the mammography, the OSD, and all that. But I can see in our experiences, this type of therapy gives really good results in mild or moderate degrees of MGD. And I will show you a study on that. It's well tolerated by the patients. In the other one, with the humid heat, it's not that well tolerated. It's very easy to apply in the office by the technician staff. That really makes our times more efficient, and it's very accessible. And both the cost of the system and the price, because that we can charge to the patient, because we don't have this disposable that creates an extra charge on the patient, and the number of patients that we can treat in a morning or an afternoon, or the time that we devote for the treatments. Next, please. And this is what I would like to share with you. We did this study using this triple therapy in evaporative dry eye using the cataract. The only difference with this, the MGRX, is instead of using dry heat, that is very convenient from MGRX, we use humid. Humidity, we use the blefasteem in that case. But as you can see in the study, and you can check it in the web, but we have an decrease in the number of symptoms according to the OSD after 3-week sessions, and we improved in the breakup time, the image of the meibomian gland. So I'm expecting pretty much the same results with less intervention with the MGRX. Next. So we, as I mentioned just to show what all the different treatment options that we show to our patient. Well, now we are considering, and we, as long as it's liberated after our clinical research, is part of our therapeutic strategy in what we call incremental complexity. We are seeing this approach very easy for, as I mentioned over there, we plan to use it in mild and moderate MGD in preoperative patients of LASIK, cataract, and glaucoma. Because it's very accessible, it's not time consuming. The patient don't consider that being has an invasive treatment before they have the surgery that they are seen to have. And also, I want to bring your attention to geriatric population. It's really well tolerated with this type of patient. And I think this is another population that we are looking into how to say to promote more in that type of patient. And we are evaluating, since we have the experience with this young, early teenage or patient, really to see to increase the number of patients in that case. So we have as our first approach for MGD, the MGRX system, and then we can move to the other one, the blefasteem, and then has very more severe IPL or other type of approach. And I think this is the last one, David. And
yes, yeah.
I want to thank you for the
thank you very much. That was really excellent, and the amount of work you've done in this area is amazing. I can see that COVID probably slowed you down, but you're yeah, I know. Not only are you doing this pilot study with us, but then we're going to do a larger study as well, so we're looking forward to that. And let me just remind everybody, if you've got any questions for Dr. Valdez and or myself, go ahead and put it in the chat and we'll take a look at that. I've got probably 5 minutes left here. I just wanted to share. We do have one clinical study that's done and should be published really any day now. So I can share that with you. And then I just wanted to tell you a little bit about if you're interested in trialing the MGRX and kind of what the pricing is and all those good things. So the study that we have completed was 37 patients. So it's 74 eyes, is the way we like to talk about those things in ophthalmology. And we did used kind of gold standard measurements. So tear breakup time, we use speed score in this one instead of OSDI. And all the standard screening was done, of course. One 10-minute treatment using the MGRX was provided to the patient if they met, the inclusion criteria. And then we did collect meibomian gland scoring as well, pre-treatment, and then at a follow-up 30 days post-treatment. So I can show you here. So yeah, 72 eyes. That's right. We had one dropout. So speed score, this is considered moderate to severe in terms of dry eye symptoms. And then after 30 days, we had a 42% improvement in speed score. So that's pretty significant. Again, just one treatment, one 10-minute treatment. And in terms of tear breakup time, actually, almost or more than doubled tear breakup time in 30 days. So this is, in line with the best studies that have been published in terms of these types of devices for dry eye and MGD. And here's the gland scoring. This one is really pretty impressive. And if you don't know how this is done, I mean, basically you're rating whether or not glands are putting out a clear liquid, if they're not producing at all, or if it's a chalky kind of toothpaste looking meibum that's really solidified. And so what you're seeing here is that these patients had very few glands that were actually producing anything. That's why their scores are 5. I mean, that's very low. So after one treatment, you're in the 20s. So that means you're going from maybe 3 or 4 glands that are actually producing to 5 or 6 or 7. And that's where I think the real, benefit, where patients can really feel the difference. We didn't include them in here, but we got, we had some patients who weren't able to wear their contacts prior to treatment. And then after treatment, they were wearing their contacts again for 6-8 hours a day, something they hadn't done in years. So it really can be, kind of life-changing if you've really got a severe issue with your dry eye. So actually, this is my last slide. I see we've got one chat. I hope we can get some more here. So if you are interested in adding the MGRX, to your practice and to your tools, again, it's the only device that has kind of this triple modality all in one. And if you want to add some of our other products for home care for your patients, it's pretty easy to do. And with just a 2-case per commitment, you can actually get an MGRX at no cost. We'd actually provide that to you. It's a 24-month commitment, and we're happy to kind of go through those numbers. For any good sized practice that's really doing a good job with home care products, this is pretty easy to do, and you can combine, mix and match all our products and change them, on a monthly basis if you wanted to. Or if you just wanted to purchase the MGRX just straight out, we are offering through the end of August a $3,000 discount. So it's about $10,000 to take this to your practice. Again, 4-year bumper to bumper warranty. There's really nothing that anything were to go wrong, we just replace the device itself. So really no concern there. And we do also offer a 30-day no risk return. And just one last on that, we do also offer a 30-day trial. So if you are interested in trying this, I know if you haven't used it, you really want to get it in your hands. That's the best way to use it. So thank you very much for that. You can call us, you can email us to set up a trial. It's also on our website. Dr. Valdez, I did have just one kind of clarification. You mentioned your nurses and them feeling like this didn't take a lot of time. When you and I were speaking, I think, and I don't want to put words in your mouth, but I think you said that your nurses are actually doing the MGRX treatment start to finish.
Yeah, from start to finish. They do it. That makes my time more efficient on that.
Right. Yeah, I wanted to make sure we were clear on that, because obviously your time and doctor's time is very, scarce and important. So if you can have your staff do it, that's tremendous.
We have a couple of questions in the chat.
Yeah, let's take a look. Okay. Oh, how long do you need to sterilize the tips for use on another patient? What do you do there, Dr. Valdez?
They clean it with the typical chemical agents that they will use for cleaning, so no more than 5 minutes.
Yeah.
And this is a good question. I will ask also you, David. They were proposing, because we have this short cycle estatin device that can be used in 5 minutes.
Yeah, like flash sterilization.
Yeah,
I think it's called. So yes, so it's a great question, Dane. Thank you. So absolutely, you can sterilize these. The only restriction would be on the expressor.
Yeah.
So
plastic.
The expressor. This is not plastic, but it is a medical grade polycarbonate.
Okay.
But it can only take 200 and it's in the manual, but 240 degrees Fahrenheit. I think it's 120 C. So if you can keep your sterilization, at that point, then you should be fine. I know because this one, in fact, was warped at 275 degrees at somebody's clinic. So, so that'd be the only restriction. Yeah.
And there's another question by Jane.
What type of battery?
Yeah.
So the device is, obviously comes with a lithium ion battery that is rechargeable. There is, we talk about a 4-year warranty. There is a required maintenance at 2 years. So after 2 years, you do need to send us back that device. And if you're in another country, typically we're going to have a service center there. But basically, we're going to recalibrate the device. We're going to replace the battery, and we're going to send it back to you with another 2-year warranty. And the reason being is just like your cell phone, after 2 years, that battery is going to be just about shot. It would still work, but we're actually testing the temperature at the tip of these instruments 1,000 times a second. So we're using a lot of battery that you wouldn't think, even forgetting about the heating, we're actually using battery quite a bit and asking that battery to be very responsive to turning heat on and off in response to the temperature. So long story short, 2 years, it has a built-in countdown basically that's going to remind you need to send that in for a 2-year service. And that's the only service that you would need. Yeah. All right. Well, I guess that's all the questions we had. I'm sure we'll get more as we post this and send it out, to the many people who requested it. Dr. Valdez, I want to thank you again very much for your time and the excellent presentation. I've obviously seen a lot of these, and the fact that you get to use your own research to kind of build your presentation is pretty amazing. There aren't a lot of docs who could do that. So thanks again, and I look forward to working with you as we move forward through these studies and seeing you in person there.
No, thank you very much for the opportunity, and I want to thank